in this analysis of the sponsored Allogene work that has a interesting history because, of course, these were the founders of Kite, and then they've moved on to a new project. Here today, we're seeing the first published, presented observation in lymphoma that we might be able to take it out of the can and have super donor cells, allogenic, and as you suggest, prepared to become a little stealth-like. And the stealth-like notion of this is deep lymphodepletion of the recipient in the setting of making the CAR itself somewhat resistant to the lymphodepletion by removing CD52 using TALON-type technologies, and then avoiding the cell against the recipient risk of graft versus host disease by removing the alpha chain of the TCR. And so both of these efficiencies are only limited by the current level of technology, which is not better than about 85%. But what is interesting is that the two genetic modifications are occurring in the same cells. And so the cell that gets TCR knocked out is the same cell that has the CD52 removed and therefore now resistant to an antibody against CD52 lymphodepletion.
And by the way,
the other cells.
If there are some cells that didn't successfully have 52 knocked out, they get knocked out by the lymphodepleting alemtuzumab-like antibody that's used as in part of the protocol. So
that's exactly what I'm saying. Yeah.
Yeah. So you're right. You get a mixture when you make these cells. You get a mixture of cells that have knockout of CD52, cells that have knockout of TCR alpha, and cells that have knockout of both. And all of them, or not all of them, but most of them, of those three variants are going to have a CAR receptor. So this is a multiplex genetic engineering event, which I think the two of us with gray hair get very excited when we see.
Yeah, we're very excited. And the estimate, of course, is you make a product that is uniform.
Well, what do the younger people
think? 100.
I want to know what the younger people think, particularly Loretta, because she's down there, where Safa is, and she probably saw some of these. They were probably her patients.
The most striking thing is we identified a patient and treated within 2 weeks, which I think really gets to the point of you've got one shot at this. You need time matters, get it in quickly. One of the potential caveats to this specific agent, though, is they had rituximab built in as a safety switch, was part of their earlier development. And so you had to have patients who didn't have recent rituximab, or at least not much circulating rituximab. So that did limit some of the application, but that's going to go away in the next iteration.
Yeah, because that doesn't happen in Philadelphia, that you have a lymphoma patient that's failing that has no Rituxan in their system. I don't know about other places. But
what do people feel about lymphodepletion with a CD52 antibody? These are, David mentioned it's deep lymphodepletion. Is that a price?
It's a risky business.
Well, there was, I think overall though, the toxicity profiles, like you would predict a lot more viral reactivation. There was some CMV and EBV reactivation that was reported. I think with the advent of things like letermovir, that could, mitigate some of the issues that we're seeing. But it's like bendamustine, it does have implications for long-term deep lymphodepletion, although it took a couple, I think it was 2 or 3 months before you actually saw ALC recovery that probably would be sufficient for harvesting for an autologous product in that case.
So again, full disclosure, I'm an investigator, right? So I've seen some of this. I will only speak to the 23 patients that are presented at ASCO today. There is no neurotoxicity so far. Zero, zip, nada, nothing. There's no GVHD, none. And there is massive expansion of these CAR T cells in the patient with, again, greater than 60% overall response rates, greater than 50% complete response. And they're showing some durable responses in the total cohort that are CR greater than 37% out of the can with low doses. And if you go to the higher dose, and again, the higher dose infusion is 360 cells, 360 million per recipient. The 3 dose cohorts were 40, 120, and 360. And in the 360, those numbers are greater than 50% CR rates, which is really something. But I think that, Matt, what you're saying is that if you knock out other cells besides T cells using a CD52, you may be removing a lot of the neurotoxicity triggers, and the monocyte and myeloid cells may be getting profound depletion in addition to the T cells.
Yeah. I mean, I mean, you would expect you're not going to see much IL-6 at all because you're killing all your macrophages with the anti CD52. I mean, in fact, that's probably a good agent to treat patients with refractory CRS with. You know, I mean, but the risk is, as I think, as somebody was pointing out.
We all said it. We all said it.
Yeah, everybody said, you know, you have to pay, you know, price for that lymphodepletion, and that's infection, you know, and potential viral reactivation. And you're mentioning strategies to get around